Hello, my name is Judith Broll. I'm the Director of Professional Development at the Royal College of Speech and Language Therapy. I am a speech and language therapist by background. I have been a college dysphagia advisor for many, many years. And before I took up this job in late 2019, I have been a speech and language therapy manager. I have recruited into roles that needed dysphagia-ready people, and I have also done a lot of training on post-basic dysphagia courses. The reason that I want to talk to you today is about the newly launched Royal College of Speech and Language Therapy Eating, Drinking and Swallowing pre-registration competencies, which I think will be transformational for the profession. I think it is fair to say that since I've been in this role, the profession has undergone and it continues to be under extraordinary challenge, both externally with things like COVID, workforce transformation, but also internally about how we perceive ourselves as a profession moving forward into the 21st century. The Royal College of Speech and Language Therapy and Health Education England have funded this project for all nations. The money has kindly come from England, but it is very clear that it will be spread across all four nations equally. And we are working together to support the whole profession to deliver these competencies, which is going to start in the curriculum from September this year, 2021. I think this is an era-defining opportunity for the speech and language therapy profession right across the United Kingdom, not only to own the title of the lead profession in the assessment, diagnosis and management of eating, drinking and swallowing, but also to ensure this is embedded into the beginning of speech and language therapy training programmes. What this programme will do is to allow students to perceive the service users as they work in a real-time holistic way and hopefully demystifying the issue around EDS and ensure a more future-focused workforce. It isn't anticipated, and we never want all speech and language therapists to work in EDS on graduation, but as the prevalence and spread and incidence of EDS is growing, I think it is only within our ken to be able to understand and recognize this, and then to be able to manage the patient holistically as a result. This framework really has its origins from discussions with HEIs and clinicians who have been instrumental in planning these competencies, and this framework will allow future employers to have a confidence that all newly qualified practitioners will have the same level of skills and knowledge in EDS, irrespective of where they studied. This will also enhance our relationships with international colleagues who have also requested a more robust EDS training and alignment, which will also help with the transition of workforce once we're allowed to leave the country safely. These competencies will also support placement expansion opportunities, as we suggest that we can expose these students to all clinical areas, because let's face it, there's very few who have any EDS, don't have any EDS challenges, potentially opening up new avenues for placement or employment offers later on in their careers. To support HEIs and clinicians alike, we've also been given a pot of money to deliver simulation training opportunities to support delivery of this framework, which is another innovative approach to training for our future workforce, and hopefully to take some pressure off frontline clinicians and indeed frontline HEIs as well. This work has been needed for a long time. I know as a manager of a service, an acute trust, we have needed this for a very long time. And we're also very mindful at college, and me in particular, that this is only the beginning of this ongoing transformation of the EDS dysphagia competencies. Once we have moved the start of the EDS training back into pre-registration, which is what we're about to do in 2021 in September, we're planning on reviewing and updating the current Royal College of Speech and Language Therapy Dysphagia Competencies framework, not only to reflect the amendments made already, but also to align it with other training structures that have been put in place since the original competencies were written. I'm thinking about, for example, the 4 pillars of practice. The idea that this work will start in the first quarter of 2022, so we would really appreciate your thoughts, and if you'd like to get involved, we'd love to hear from you. I think that the last thing I would really like to point out to you really is that this work spans all areas of the speech and language therapy profession, and we're all in it together, from HEIs to students and to clinicians, and ultimately this will benefit service users. It is also iterative. We are all learning together, and it will be reviewed and improved and will ultimately continue to evolve as we work together to support and embed this important piece of work into the day-to-day workings of all speech and language therapists in the future. So wish us all a good bit of luck. Thank you very much for your time, and we look forward to working with you. Thank you.
Hello, my name's Hannah Crawford. I'm one of the co-lead authors of the Eating, Drinking, Swallowing competency piece of work for the Royal College of Speech and Language Therapists, and I'm also professional head of speech and language therapy at Tees, Esk and Wear Valley's NHS Foundation Trust. I'm here today just to give you a very quick overview of the eating, drinking and swallowing competencies, to talk very briefly about what they will and won't do, and just to give you some of my perspectives as a speech therapy manager. So in terms of what the quick overview should be, is that what we are hoping to equip our entry-level speech and language therapists to be able to do is quite kind of basic level competencies within dysphagia, and some of those will take place within teaching sessions within the university, and some of the competencies will be gathered while in clinic. And we envisage that this knowledge, skills and competency will probably be gathered over the period of their training, but actually a lot of these are transferable skills that they will be learning within other clinical presentations, but those skills are common to a lot of the areas that we work in. So they're things like being able to understand and discuss eating, drinking and swallowing issues, but also discussing those issues with service users, families and their carers, and to gain an understanding of the difficulties from their perspective. We are aiming that the entry-level speech therapists will be able to take case histories, and that will include some face-to-face discussion and taking relevant information from case notes. So they'll be able to recognise difficult eating and drinking presentations and discuss hypotheses in relation to these, and understand some possible interventions, including the reasons for and against things like non-oral supplementation. They'll be able to use some assessment methods, and they'll work in a person-centred way to develop diagnoses, intervention plans, outcomes and review and discharge, and also to discuss ethical issues in relation to eating and drinking. So you can see that while the clinical focus of that is dysphagia, a lot of those skills are transferable skills when we think about communication. The aim of the competencies is that they will allow a newly qualified speech and language therapist to enter the workforce ready to undertake guided dysphagia work with what we might class as more straightforward cases, in exactly the same way as we would expect them to be able to work with communication presentations. So we would expect these individuals still to potentially need to work closely with other experienced speech therapists and to build on their competencies and develop their expertise within the fields that they're setting. In the same way we would support supervision and actually mandate supervision for speech and language therapists throughout their career, then the newly qualified speech therapist will require supervision to work in dysphagia. This level of competency will not equip them to work autonomously with complex dysphagia cases, and it won't equip them to work with some of the more specialist areas, but it will give them an awareness that those areas exist. So as a manager, for me, pretty much in all of the services that I lead, service users present with both communication and dysphagia difficulties. And so having speech therapists being able to work to some degree with dysphagia will be much more focused and a much leaner way of working for a speech therapy department, but also for that service user and their families and carers. So they have one member of the speech therapy team who's primarily responsible for their assessment and care, although we would be expecting that speech therapist to go back for support from more senior colleagues for every element of what they're delivering. But in other areas, it may be that in the past, we'd have had to have a speech therapist working to support communication and somebody different offering the dysphagia delivery.
Hi everybody, my name is Paula Leslie and I'm a speech and language therapist. I'm born and bred, raised in Britain in the NHS. I qualified in 1995. I had absolutely no interest in working in the whole area of eating, drinking and swallowing issues. It wasn't in our scope of practice. All I wanted to do was work with adults who stammered. That was my starting position. But I Went to work in a general service. I worked in paediatrics and adults in schools and outpatients and hospitals. And if you did any of that kind of practice, you would always end up working with people post-stroke, people with progressive neurological conditions, young folk with conditions like cerebral palsy, and the whole eating, drinking and swallowing, or dysphagia work, as it was termed then, crept into my practice before I was trained at university, if that makes sense. And I got sent away for a week to darkest Manchester to do a post-basic training course. And that's how it was, learning on the job in those days, and being sent away, or sometimes if you had a good in-house service. And so I'm skip on forwards to 2021. I'm really excited that we have a robust structure for getting this learning recognised within our educational system. So my voice here is that perhaps of the academic, the higher educational institution. And I say recognised because I know that most of the content, if not all, has been in our academic curricula for years. And the practical components have also been in very many pre-registration and post-registration programmes. And so what we're trying to demonstrate here is that we already do this thing. So let's think a little bit about history for a moment. In 1995, dysphagia in the pre-registration programs was written about in a document. And it was formally acknowledged, if you like, that this is part of our scope of practice as speech and language therapists in the UK and speech language pathologists in other parts of the world. 2013, it was recognised that that 1990 document needed a bit of an update. There were a number of things that were happening at that time. There were changes in the health service, there were changes in education. And although I was in the USA at the time, I was involved with a big group of people who wrote the dysphagia training competency document. So that's the, none of us can remember the title of this thing, but that's the DTCF document, the framework document. There is the kind of levels A through D that we may be familiar with, and that's one document in our past and current. And there's another document which is an interprofessional training document, and that also has standards, but I'm not really going to talk about that. And that document in 2015 was due for review in 2017. And that has not really happened. Lots of other things were going on in the last few years. But the RCSLT, if we skip forwards now to the RCSLT reason for existence, the statement on the very front page of our professional organisation is that our role as speech and language therapists, not the professional body, but us as individuals, is to create better lives for people with communication and swallowing needs. And I think that's so perfect compared to some other mission statements around the world that get long and flowery. This is what we do. We create better lives and we support people to live the lives that they have to live with whatever impairments or conditions they are trying to deal with. And in our learner pages on the RCSLT website, there's a really nice handout, a flyer, a PDF. What is it that speech and language therapists do and who benefits from our services? And this is a direct marketing tool for people considering the profession. And on this handout, this PDF, we have that the populations we serve, and I really like that term, we serve, covers people with congenital conditions, with syndromes, with developmental, acquired neurological and structural conditions, you know, across the gamut. Almost every condition that we work with, or person rather, and family with a condition that we work with, that we maybe historically thought of as relating to communication, comes with it a high likelihood of there being eating, drinking and swallowing issues. It's part of the package of a child with cerebral palsy, of a young mother who's just had a head and neck cancer, a reconstruction, of the grandparent who's just had a stroke or maybe has a progressive condition like Parkinson's disease. And so this is recognised within the national clinical standards, the HCPC standards of practice. And if you want to go dig around in those documents, if you've got nothing better to do in lockdown, particularly standards 13 and 14, key concepts and knowledge, and drawing on this knowledge to inform our practice, mentions in several subpoints of those sections not just communication, but eating, drinking and swallowing. And they go together because people recognize that the condition causes certain challenges for people, and the condition comes then with communication or eating drinking and swallowing problems. We don't separate those things out in the condition of Parkinson's disease. So I'm keen that we talk about eating, drinking and swallowing issues rather than the historical term dysphagia. And I do that because dysphagia tends to get us focusing very much on the biomedical model. And when we set up the UK Swallow Research Group, which we have at this biennial conference, which many of you may have attended, we deliberately chose to call it the UK Swallow Research Group, not dysphagia, because what we're looking at is the swallow. And what we're looking at as speech and language therapists is the whole package that is eating, drinking and swallowing, because we work with people who struggle to get food to their mouths, who struggle to see things on a plate after a neurological condition, who have tone issues, which mean that they struggle to maintain posture to be able to get food to their mouths and to get food and drink through their systems. So it's much more complex than this sort of biomechanical focus that there has been historically on dysphagia. And in looking at eating, drinking and swallowing conditions within our great spectrum of work, we're really encouraging people to work to the full scope of practice. And just as people like myself ended up doing a lot of work in eating, drinking and swallowing, it wasn't even on my radar, right, when I was at university, it was not on my radar. But it's become a really fulfilling part of what I do. And I'm sure there's many experienced clinicians out there would say the same. It just, it wasn't on the radar to start with, and then here it is. So I think as academics and as educators, we should embrace this thing as much as we already do, and perhaps more so in some cases, to support our learners to hit that workforce ready to cope with the basics across the full scope of practice, which is tremendous. We have a tremendous practice. And thinking about checking boxes in the world of academia, I've just been involved in a nation's academic review of all their clinical programs. This term interprofessional working or multidisciplinary working is all over the place, right? We've got to check lots of those boxes at university. And interprofessional working is so great if you think about eating, drinking and swallowing, because perhaps unlike communication, where we are the absolute top dogs, I think, in terms of eating, drinking, swallowing, we think of physiotherapists who might help with posture, as I mentioned. We might think of occupational therapists who work with modifying utensils and environments. We might work with dietitians. We might work with a host of health and social care professionals to support that person. So it's a really great avenue for dealing with that kind of stuff. And when we think about this term interprofessionality, that's very popular in the USA, and it's creeping in here now more so than multidisciplinary perhaps. It allows us to serve the needs of the whole person in front of us. And it is perhaps a consummate concept, a consummate example of how our profession can serve support the care of the whole person who's in front of us. And that's why I think it's so great. Let's do it.